Hello there. My name is Jesse Powers. I'm a student at the OHSU School of Nursing, and I'm going to talk to you about acute kidney injury. Just a quick overview to begin. We're going to look at the kidneys, what their function is, and what the functional parts of the kidney are. Then we will look at acute kidney injury. This includes how AKI is classified and what some of its effects are. Then we will go into what the phases and types of AKI are. And lastly, we will look at how AKI is identified, what some of its comorbidities are, and what kinds of societal impacts AKI has. After that, we will take a quick look at hospital-acquired AKI, and then finally, we will look at what the future holds for AKI diagnosing and potential guidelines in relation to AKI development post-surgery. So this is the kidney. The kidney's main function is filtration, maintaining fluid and electrolyte balance, and the excretion of waste products via urine. The kidneys are also responsible for hormone production, such as erythropoietin, which stimulates the production of red blood cells, renin, which is part of the RAS or renin-angiotensin-aldosterone system, which helps maintain osmotic balance, and calcitriol, which binds to vitamin D receptors and promotes uptake of calcium in the intestines. The kidney is made up of three principal areas: the cortex, which is this outer shell right here, the medulla, which is this inner section right here, and the renal pelvis, which is actually this orange section right here, which is where urine flows into. The functional status of the kidneys is measured through laboratory values, including urinalysis, blood urea nitrogen, serum creatinine, and glomerular filtration rate. So here's another view of the kidney. You look here, this is the cortex, this outer shell right here. This is the medulla right here, and then this is the renal pelvis. This right here is the renal artery, which supplies blood to the kidney, and then this is the renal vein, which blood returns back to circulation through this. So the kidneys take in blood through the renal artery, which is then filtered and returns to circulation through the renal veins. Filtration takes place within structures called nephrons within the kidneys. Filtration is driven by blood pressure. So if you take a look down here, this is actually a nephron. And the filtration actually takes place in this right here, which is called a glomerulus. So these are tiny little arterioles. This is driven by blood pressure, which forces water, waste products, electrolytes, and nutrients out into the glomerular capsule. It then travels into the proximal convoluted tubule, travels down this section here to the ascending limb of the loop of Henle, up the descending limb of the loop of Henle, and then up to the distal convoluted tubule. Then finally it arrives at the collecting duct right here, which then travels to the renal pelvis right here, and then it travels down to the ureter, and then finally it goes to the bladder. At different sections of the nephron here, different nutrients, electrolytes, and water may be reabsorbed back into circulation. So again, electrolytes and water may be excreted or reabsorbed in the nephrons to maintain fluid balance within the body. Waste products are filtered out of the blood in the nephron, which move to collecting ducts and eventually the bladder for excretion, just like I said. Surprisingly, some of these waste products may actually be reabsorbed into the body, such as urea, just to maintain a balance within the body. So now finally, we have acute kidney injury. So acute kidney injury, or AKI, is a term used to denote a rapid decrease in kidney function. AKI was formerly known as acute renal failure. They switched over to calling it acute kidney injury because acute renal failure was too broad. They wanted a term that showed more gradual changes in kidney function. So mortality rates in critical care patients with AKI can be as high as 70%. So that shows you how dangerous AKI can be. Although there is no clear definition for the diagnosis of AKI, several criteria have been developed for use in research studies to help classify a patient as having AKI. So a widely accepted definition of AKI is 50% or greater increase in serum creatinine level above normal. Those with recurrent episodes of AKI may develop chronic kidney disease. So acute kidney injury is reversible, but if you have recurrent episodes, it may eventually lead to chronic kidney disease. So now we have the effects of AKI. So the first one is azotemia. Azotemia is where you get a buildup of waste products in your bloodstream, specifically creatinine and urea. One interesting thing is that as urea levels rise in your bloodstream, you can develop something called uremic frost. Uremic frost is where the urea levels in your blood get so high that you start to excrete urea out of your pores and you develop a white frosty substance on your skin. Another thing that can occur is encephalopathy. As these waste products build up in your blood, it can cross the blood-brain barrier and then cause encephalopathy. Another effect is reduced GFR, so the kidneys are damaged and then they're unable to filter waste products, water, everything out of your blood. Oliguria, which is a production of urine less than 400 milliliters per day, and then eventually you can develop anuria, which is less than 50 milliliters of urine per day. Hypovolemia and hypervolemia. So hypervolemia is the most common. So your kidneys are unable to produce urine, and so you get elevated levels of fluid within your blood, and then you develop hypervolemia. Hypovolemia can occur actually after the oliguric phase, which we'll go over here in just a second. In the recovery phase, you can actually start to excrete too much fluid out of your body, and then you can develop dehydration and hypovolemia. Hyperkalemia, so you get too much potassium. Your kidneys are responsible for excreting potassium out of your body, and so when they can't excrete that potassium, you develop hyperkalemia. Anemia, so your kidneys are responsible for erythropoietin. Erythropoietin stimulates red blood cell development. Without this, you can develop anemia. And then electrolyte imbalances like sodium, potassium within the body. So these are the phases of AKI. First, you have the initiation period. This begins with the initial injury and ends with the development of oliguria. During this time, you may have no visible symptoms, or you may have decreased urine output or GFR. Then you have the oliguric phase, which begins with the development of oliguria, which again is less than 400 milliliters of urine per day. You also have increase in serum levels of waste products and electrolytes, which are normally excreted by the kidneys, and most of the time you have decreased GFR. Then you have the diuresis phase. This is actually the beginning of the healing phase. So you have a gradual increase in urine output, your serum levels stabilize, and then, like I mentioned before, urine output may exceed normal, so you actually have to watch for signs and symptoms of dehydration. And lastly, you have the recovery phase. So this is a gradual improvement in renal function. Complete recovery may take 3 to 12 months, so this is a long process. Here we have the types of AKI. You can take a look at this drawing over here. So you have, this is normal right here. So you have good blood supply, good return, and then you have good urine production. There are 3 types of AKI. So you have pre-renal AKI. That's where the cause originates before the kidneys. This occurs due to decreased perfusion to the kidneys. As you can see here, this kidney is very thirsty. He doesn't have enough blood supply going to him, and then he's not producing a whole lot of urine. Then you have intrarenal AKI. This is where the cause originates from within the kidney, and it occurs due to damage or inflammation in one or more areas of the kidney. So you can see here he's not feeling very good. This is intrarenal. And then you have postrenal AKI. This is where the cause originates after the kidney, and it occurs due to blockage of urine from the kidneys. So you can see that the ureter right here is constricted, and then urine isn't able to exit the kidney and flow to the bladder. So here we have pre-renal AKI. Again, you have this little guy here, he's thirsty, he's not getting perfused, and he's not creating urine. Pre-renal AKI is caused by absolute or relative decreases in circulating volumes or abnormalities of renal hemodynamics. So absolute decreases in volume can be caused by hemorrhage. This can be due to injury, hemorrhagic stroke, or complications from medical procedures. Dehydration, this can be due to fever, diarrhea, vomiting, other medical conditions, or electrolyte imbalances. Another one is age. So older people have a diminished thirst response and then they don't drink water. And this can cause dehydration and then poor perfusion to the kidneys. Then you have burns. Burns is huge. You're losing a ton of fluid through those wounds or sores on your body. And then you can end up dehydrated, hypovolemic, and then you're not going to perfuse your kidneys. And then lastly, you have overuse of diuretic therapy. Then you have relative decreases in fluid volume. This can be distributive shock, so septic or anaphylactic shock. This is where your body shunts blood away from non-vital organs. So it's only going to be supplying blood to the vital organs. So the heart, the brain, the lungs. It's trying to keep you alive. It doesn't need to supply blood to non-vital organs such as the kidneys, the liver. Then you have third spacing and edema. So this is where fluid collects in different parts of the body. That could be in the third space or it could be in your limbs. And then finally you have decreased cardiac output. So anytime you have decreased cardiac output, you're not going to be perfusing or supplying blood and oxygen to different parts of the body, and then that can cause acute kidney injury. So this can be caused by cardiogenic shock, dysrhythmias, cardiac tamponade. It's where you get fluid in the pericardial space and then the heart can't pump. You have heart failure and myocardial infarction. Lastly, you have abnormalities of renal hemodynamics. This is occlusion or stenosis of renal arteries, so blockage of blood supply to the kidneys. And then you have drug-induced impairment of renal self-regulation. So this is drugs which affect the kidney's ability to self-regulate blood flow into the kidneys or self-regulate outflow, affecting filtration rate. So the kidneys have the ability to dilate or constrict blood vessels in order to regulate filtration rate. And so certain drugs affect this. Next we have intrarenal AKI. So again, this is inside the kidney. You got a little sick kidney, doesn't feel very good. So AKI caused by damage to one or more of the areas within the kidney itself. These areas include the tubular, glomerular, interstitial, and vascular tissues. So tubular, which is usually acute tubular necrosis, is damage to the renal tubules caused by ischemia or toxins. So ischemic causes are prolonged prerenal failure. So ischemia leads to cellular hypoxia, leading to cell death and damage. Transfusion reaction. So if you have a transfusion reaction, it may cause fever, hypotension, and kidney failure. And then rhabdomyolysis. This is usually due to a crushing injury. So this is the breakdown of muscle tissue, releasing their components into the bloodstream, causing higher than normal concentrations of creatine kinase, myoglobin, and electrolytes. This overwhelms the kidneys. This actually causes a blockage at the glomeruli, and then the kidneys cannot filter anything because it's physically blocked. Next, you have nephrotoxic causes of tubular necrosis. So radiograph contrast media. This is huge too and very common. So contrast media causes toxicity damage to the renal tubule. I put a little note here. So 12% of AKI development within the hospital is due to the use of contrast media. So this is really big for the development of AKI. Next, you have antimicrobials. So these are antibiotics. So some may be nephrotoxic, causing damage to renal tissue. They may affect GFR or inflammation. So some of these are aminoglycosides, such as gentamicin, tobramycin, polymyxin B, which I don't even know what that is, vancomycin, and cyclosporine. Then lastly, you have recreational and over-the-counter drugs. This may cause kidney damage and eventual failure. So again, hard drugs are going to cause kidney damage. And then over-the-counter NSAIDs. So NSAIDs cause a lot of kidney damage, and overuse of NSAIDs can actually cause intrarenal AKI. We have a couple more intrarenal AKI causes here. So glomerular, so acute glomerulonephritis, this is inflammation of the actual glomerulus. Then you have the interstitial. These are basically dealing with the tissues. Interstitial, which is acute pyelonephritis, this is a bacterial infection of the kidney, causes inflammation in any of the itises. And lastly, you have vascular. So this could be an emboli, so a blockage of blood supplying renal tissue, or vasculitis, inflammation of the arteries of the kidney. So both of these are going to be blockage of blood supply causing damage to renal tissue, which causes the development of AKI because the kidney can't function as well as it should be. Same with glomerular, so glomerulonephritis, inflammation of the glomerulus, and then you're not going to be able to filter properly, your GFR is going to drop, you're going to develop AKI. Pyelonephritis is the same thing. So post-renal AKI is caused by the obstruction of urine out of the kidneys, so the guy's all swelled up, he can't get urine out. Benign prostatic hyperplasia, that's enlargement of the prostate in men. Kinked or obstructed ureters, so physical blockage. Intra-abdominal tumors, again causing blockage. Strictures, which is scarring of the urethra, obstructing flow of urine. These strictures build up scar tissue, which eventually blocks the outflow of urine from the kidneys. The urine backflows up into the kidneys, causing damage. And then you have calculi, which is kidney stones, which is deposits of salts and minerals, which obstruct the flow of urine out of the kidney. So now we're on to identifying AKI. So the KDIGO, or Kidney Disease Improving Global Outcomes, has created a set of criteria for identifying AKI. So the presence of any of the following classifies as AKI. So that's just one of these, not all of them. And this is just a little bit more specific than that 50% increase over base. So an increase in serum creatinine by 0.3 milligrams per deciliter or more within 48 hours, an increase in serum creatinine 1.5 times or more baseline within the last 7 days. So again, this is that 50% increase above baseline. Urine volume less than 0.5 milliliters per kilogram per hour for at least 6 hours. And then we have some lab values used to identify AKI. So serum creatinine is kind of the gold star. This is the one that everybody looks at when identifying AKI. So elevated levels indicate decreased kidney function. So the kidneys work to excrete creatinine through urine, and so when you have elevated levels, that can indicate damage. Then you have blood urea nitrogen. Elevated levels that coincide with increasing creatinine indicate AKI. This one, however, it can be heavily affected by diet, specifically protein intake, so it's not as accurate. The bun and creatinine are actually used in a ratio which is 5 to 20. So 5 blood urea nitrogen to every 20 creatinine is normal. Then you have GFR, or glomerular filtration rate. This measures the volume of fluid filtered by the glomerular capillaries in the nephron of the kidney. So decreased GFR is indicative of AKI. And lastly, you have urinalysis. So this can be used to measure mineral content of the urine as well as other indicators such as proteinuria, or blood in urine, hematuria. Now we have some comorbidities. Atherosclerosis, so this is plaque buildup. This is a lack of perfusion to the kidneys due to this. And then you have hypertension. Hypertension actually causes overperfusion by the kidneys, which damages them. So too much pressure causes them to filter too much, which actually can damage the kidneys. You have diabetes. Diabetes causes diabetic nephropathy, which is the most common cause of end-stage renal disease worldwide. So this is sugar buildup in the blood, gets filtered through the kidneys, and then it flows through the efferent kidney vein, or renal vein, which causes damage to the renal vein, and then it causes a blockage, which damages the kidneys. You have heart failure, and then you have liver impairment and failure. So Heart failure affects fluid balance within the body, affecting the kidney's ability to filter blood and causes poor perfusion to the kidneys themselves. And then liver failure patients commonly take diuretics, which can damage the kidney, damage and overwhelm the kidney. They're also prone to internal bleeding in the GI and commonly have volume deficit problems. Now we're going to look at advanced age and AKI. So age is the largest precipitating factor in the development of AKI. So by 70, only half your nephrons still work, and by 80 years old, a person's GFR is half what it was at 30. Some age-related changes include decreased ability to concentrate urine, decreased ability to regulate perfusion pressure at the kidneys, decreased ability to retain sodium, and decreased potassium excretion due to lower aldosterone levels. You also have a decreased response to ADH, decreased thirst response, as I mentioned before, and increased fluid and electrolyte imbalances. You have a decreased GFR due to the diminished number of nephrons, and then kidney cells are more prone to damage due to age. Now we're going to look at some societal impacts. So some financial implications for AKI. So AKI development in the hospital may increase length of stay for patients. This means increasing costs. And then missed time from work for patients or family due to time spent in the hospital means they're making less money. So the patients are spending more and they're making less. Some ethical implications. It is the role of the nurse to promote a healthy lifestyle and aid in the prevention of AKI. So this may mean addressing the comorbidities which may lead to AKI. This aligns with the ANA Code of Ethics Provision 5, which states it is the nurse's duty to promote health in themselves and others. Some potential legal implications. So they're considering adding hospital-acquired AKI as a patient safety indicator for government and private regulatory agencies. So if this is added as a PSI, that would mean that it could be used as a quality of care indicator by private and government regulatory agencies. So they could look into hospitals and say, you guys have a lot of patients that are developing AKI. Maybe you're doing something wrong, or what can we improve to prevent this? Now we're going to look at hospital-acquired AKI. So AKI development within the critical care units and hospitals ranges from 20 to 50%. This is depending on the source. Mortality rates among those that have developed AKI in the hospital range from 50 to 70%, and I saw some sources quoting as high as 80%. So among these, populations with pre-existing conditions had the highest risk for developing AKI. Post-operative patients, especially heart patients, had the highest rate for AKI development. And as of now, there is no effective pharmacological therapy that has been shown to be completely effective to treat AKI, especially in those with late-stage AKI. Now we're going to look to the future of AKI diagnosing. So currently in development is a device that monitors PuO2, which is urinary oxygen concentration, temperature, and flow rate instantaneously. The device measures PuO2 and urine flow to identify AKI development. So according to the developers, a drop in PuO2 post-surgery corresponds to the development of AKI. The sooner you can identify AKI development, the better the outcome for the patient. Next, we have a machine learning model that was used to interpret health data and predict AKI development. So the model predicted 58% of AKI diagnosis with a mean lead time of 30 hours. It was also able to predict the development of AKI up to 40 hours earlier than traditional methods. So again, the earlier you can diagnose it, the better outcome for the patient, and the more you can do for them, and you can stop them from developing late-stage AKI. And lastly, we have KDIGO. This is the development of a set of guidelines to use in surgery to help prevent AKI development. Again, surgical patients have the highest morbidity rate, so if you can prevent the development of AKI, you can really help these patients. I want to thank you for listening and hope you have a great day.